Thank you. I thank Icon for giving me this opportunity. We are anyway running late, so I'll quickly go through this few algorithms. And I have selected CRT only, which is something that has got these newer algorithms which are going to help optimize the devices better. So I think time is less. We'll first discuss only the algorithms and not the case. So this is a very standard and a great paper, landmark paper from Jack, which clearly showed that the major reason why we have non-responder status is mainly because of optimization issues, right? This is what we have. Your optimization suboptimal AV timing is the main reason why we do not get, or we get non-responders in CRT, which comes to about 25 to 30%. And followed by that, you have got other etiologies like arrhythmia, anemia, right ventricular dysfunction, by lead not in place. Those are the other things. But primarily, the problem that we have is suboptimal AV timing, and that is something that we need to kind of concentrate when we put a device. Now, quickly cite some amount of physiology before we get in, and so that we know how we optimize our devices. And this is what happens in a normal individual. Now, if you look at, I think all of us know very well that this is what an ECG and this is your mitral Doppler that looks like. You need to have an adequate diastolic filling for having a proper output. And diastolic filling, if you look at the mitral Doppler, is formed by an E and an A. A is the atrial kick and E is the earlier filling. So this is what you need to have in a normal individual. What happens when the patient develops a left bundle branch block is there is a kind of fusion that happens between the E and A, and there is kind of shortening of LV filling in diastole, which is what is something that we need to correct. So that is what we do when we put a CRT. We try to kind of optimize this. And as you all will know that most of the time we'll put the device, we'll forget it. But if our patient is not responding, then this is something that we need to go in and sit in the echo lab to look at what is the mitral Doppler looking like. And we must try to get this kind of E and A wave. Now, you can play with a lot of things. You can play with the AV intervals. You can play with interventricular delays. But if it is important to have an optimal AV delay, because if you have got a very short AV delay, your A will get curtailed. If you have got a very long AV delay, you're going to have fusion. So you need to program in an individual an appropriate AV delay to get an appropriate LV filling. Now that will be different in different operators. So are we doing it? Now that's the question. Now, if you look at the data, answer is absolutely no. They found that only 13% of devices are being optimized with use of echo. And the reason why these devices are not optimized is either time or because there are no qualified individuals. And that is what I think the time when companies got into and thought that is better to have algorithms than depending on the cardiologist, who usually will not have much of a time. So I think that is how these algorithms have come into play. Now, what happens in a conventional BIV? In a conventional BIV, this is what happens. You kind of take away your normal conduction by the leads that you have put in. You are going to paste from the LV lead and the RV lead, and you're going to fuse both. So your intrinsic conduction, and most of our patients who get a CRT will have preserved intrinsic conduction. There is a very small subset of patients who will not have intrinsic conduction. So what we do, we put a CRT and we take away that intrinsic conduction. So the algorithms that are coming are going to utilize that. What they are going to do is they are looking at how best we can utilize. If you have got an intrinsic conduction, utilize that and try to fuse with one of the leads that you have put in. Allow the intrinsic conduction, fuse with one of the leads. That is what is the whole idea. So the goals of optimization are, you need to have proper AV delays so that you can have a good EA relationship. And there is one last line, dynamic preferred. The reason is very clear. You have put a device, you have programmed the AV delays, but remember, those AV delays are at rest. The moment the individual is going to walk, he's going to do his activities, AV delays will change and synchronization might change. So that is where these algorithms are doing better, because they are trying to make it more dynamic. So your aim of optimization is one, dynamic AV delays, and of course other things that you need to do. You make sure that intrinsic conduction is there, use it to fuse your BIV, and other causes like atrial fibrillation, PVCs, etc. Be taken care of when your patient comes to you. So the algorithms that are there, quickly going into, one is from St. Jude, and this is for Abbott. This is called Sync AV. And what they do in this algorithm is very interesting. What they have done is that the device is going to assess the intrinsic AV conduction every 256 beats. So every 256 beat, the device will look at whether the individual has got an intrinsic AV delay. And if it is an intrinsic AV delay is there, then as an operator, you have the choice to program something called as a delta. You program this delta that will be subtracted from the AV delay, and that is what the device will pace at for the next 256 beats. Now, why this? What is the use of this 256 beats? See, this makes the device very, very dynamic. Individual who is taking rest at 50, every 5 minutes AV delay will change. Whereas the individual is walking, doing activities, heart rate of 90, every 3-4 minutes, the AV delays will keep changing. So you have programmed the delta. There is an intrinsic AV conduction. It will subtract, and that will be the AV delay that will continue. So this is what this algorithm, sync AV, is going to do in a very simple way. There are a lot of other things, but I think to make it very simple, this is what the device is going to do. Now, what about before finishing, that is one thing. Second is, if there is an intrinsic conduction, then the device will go into an LV mode. That is, it will allow the intrinsic conduction to conduct and pace the LV at the programmed VV delay, and they will fuse. So intrinsic conduction, that's called LV. So this is what this algorithm will do. What about Medtronic? They have got adapt CRT, and this is also kind of a similar algorithm. There are certain caveats to it, but suffice to understand that this is also going to do the same thing. What is it? It'll do if the patient has got an intrinsic conduction, which most of our patients will have. The device will allow the intrinsic conduction and pace, and will go into an LV only pacing. That is, only the LV lead will pace, allow the intrinsic conduction, fuse it. That's called Medtronic. It's an adapt Medtronic algorithm, and only place if your AV delay is more than 250, if your heart rate is more than 100 beats per minute, or if the patient is not in sinus rhythm. Those are places where this algorithm will not work. It will jump to the BIV that you have programmed. So this is how this particular algorithm is going to work in patients where you have programmed an adaptive CRT. Now, is there any data to suggest? Yes, we have got data at this moment, and they showed that it is non-inferior if you do an echo-guided optimization. What about Boston devices? They call it a smart AV delay. Similar kind of algorithm. Good thing about Boston and Biotronic devices are that they can sense also both the LV lead and the RV lead. So this device, what it will do quickly, it will sense A to LV sense, A to RV sense, A pace to same LV RV, and then it will find out an AV delay. And also about the VV delay. The VV delay, what you can do is you have got this kind of a chart. So you can measure the VV delay. Device will tell you this is the VV delay. Will tell you between the LV and the RV delay, and you can program the VV delay. So again, additional thing here is that because you can sense the LV lead, you can also program the VV delay or the interventricular delay in this algorithm. So the advantage is that, again, data wise, they have also shown that definitely the LV volumes comes down if you program them on this particular algorithms. Biotronic, similar kind of algorithm. I'm not going deep into that. It's called an auto adapt. So essentially what they are doing is they're allowing the intrinsic conduction and fusing it, one, and two, they have made both the AV delay and to some extent the VV delay dynamic in patients whom you have put a device and you are not able to program. I think it is good if it is good for us if a patient comes as a non-responder to take them to echo lab. But if you cannot do it, I think these algorithms are doing good job, and we should be, I think, accept them. So I think I'll end it here. Thank you.